So as you travel down the road and the subtlety of every day, there's things that go by that you just don't notice. You just don't notice them. So you look at this truck in front of you, it's got a sign on it. Well, look at the sign. Some of you know this, some of you don't. There's an arrow between the E and the X. It's only been there since 1994, but it's part of our lives. Some people notice, some people don't. So even though you're thinking about thoughts you're not having yet, the next time you walk in an operating room, look at the control panel. Go straight to the control panel and notice that there's a yellow light next to the auto button. That's the default setting. That's the highest radiation exposure you can get. Look at it as soon as you go in the room. So there it is. You take your first picture with the yellow light on and then you shut it off for the rest of the case. If you know nothing else from what I say today and do just that, you'll substantially reduce your radiation exposure. There's a new digital one that has the image down on the bottom. It's a little more difficult to see, so I've used the older one for illustration, but it's there on the new ones as well. So your X-ray technologist is there in the room. What's your X-ray technologist thinking? He's thinking better hot than not. He doesn't want to get yelled at by you. He doesn't want to get yelled at by the radiologist. So he's going to put the highest amount of radiation in that picture to give the best picture possible. And he knows he's far enough away, it's not going to affect him. So that's what you're up against. You're up against better hot than not. So about 12, 15 years ago, I learned a minimally invasive spine technique that included more fluoro. I was at Meridian Park. They had a great program. I had a dosimeter underneath my gown and on the outside. And after I'd done this for a couple of months, the radiation safety officer came to me and said, "What are you doing?" Because my exposures have tripled. And so I started asking questions and I went down a rabbit hole. I ended up in a strange place where I had no idea what it was. It was like Greek. Nobody could answer my questions. I ended up talking to the lead engineer at GE who designed the OEC. I had a bunch of conversations with him. Went to Phoenix to Lou Toomey-Allen, who had published a paper with his X-ray tech. And then I pulled out the literature that was like Greek. It's like I had no idea what this was saying. But slowly, as I turned the pages and tried to absorb it, it became more like a novel. I became more absorbed in it. And it was more like the author talking to me. And it started to make sense and I could focus with me. Listen carefully to the essential information I've distilled that's valuable to your health and well-being for you and your staff in the operating room. So here's an article from 2017 from Gaudens et al., published in JAS. Radiation exposure, not surprisingly, in spine and trauma is much higher than everybody else. This is resident exposure. Attending exposure, very similar pattern. And again, not surprisingly, senior residents got a lot more radiation than the juniors. Juniors were standing back further away from the emitter. But how about the scrub tech? How about the first assist? They're there all week long. They're there every day. Their radiation exposure is substantially more. I didn't find any literature on that. Most of the literature is about us. So underestimation of fluoroscopic exposure among orthopedic residents is from 2020. 19 orthopedic residents, 13 juniors, 6 seniors. They walked out of the OR and they said, "Well, how many images did you take?" Well, there were 19 proximal femur and femur ORIF cases. As a group, all 19 residents said they took 898 pictures. Well, they took 2,056. They're off by 57%, and some of them were like off 150%. And they averaged 108 images per case. So you're thinking, did he fire 5 shots or 6? So do you count? Do you know how many images you take? It's critical to know. It's invisible, it's odorless, it's colorless, there's no immediate effects. First effects are too late and it's cumulative. That's why we don't pay attention to it. How much radiation is too much? 0.05 sieverts or 5 rem. Well, I can look at my car and know if I'm going too fast, and I can look at the gas gauge and know when I need to go to the gas station, but that number meant nothing to me. How big a number is that? How many was I getting? And who says that's too big a number? Well, it comes from Hiroshima and Nagasaki. The lifespan study, 120,000 exposed survivors, unexposed residents of all ages, over 70 years of follow-up. That's where the data, a lot of the data comes from. There's a lot of publications since that, but that's the baseline. There's two types of basic radiation: energy absorbed, biologic effect. And the energy absorbed is measured in rads, the biologic effect in rem. Energy absorbed can be gray or sieverts. And so think of it as kilometers per hour and miles per hour. A rad is conventional, a gray is international, a rem is conventional, a sievert is international. But a rad is equal to a rem and a gray is equal to a sievert, because in our world, the radiation from a C-arm and whole body radiation has no necessary conversion factor. If you're a radiation oncologist and you're using different radiation sources and you're thinking about different tissues, that's a whole different world of calculations that we don't have to agree with. But you don't have to remember that. The only thing you need to remember is rad and gray, because that's what's on the machine. And you only have to pick one. You don't have to remember the difference. Just pick one and use that as your guide. I'll show you that. The other on the machine is the CAK, cumulative air Kerma rate. It's down in the bottom right corner of the screen. It's either in millirads or milligrays. Pick one. Pick rads, pick grays, use it as your monitor, and then you can track how many images you've taken, what your total exposure is. This is a calculation, it's not a measurement, but it's a good idea of how much radiation is being released into the room. And just for example, 9.1 rads is 0.09 milligrays. You just move the decimal point to convert. So it's actually pretty easy, but you don't even have to do that. On the machine, there's KVP and MA. Those are important. You don't have to know them, but know that they're important. What you need to know is the seconds of fluoroscopy time is worthless. If I have you out 30 minutes in Portland in the rain with an umbrella over your head, and then you spend 30 minutes at the equator out in the sun, they're both 30 minutes. But the radiation is completely different. So forget about the seconds of fluoro time, doesn't help you at all. There's two agencies, there's an international and then the American national. They have a set of guidelines. That's all they are guidelines. But there's 0.02 sieverts for whole body, 0.5 for whole body. I'm going to focus on the eye. 0.02 international, 0.05 eye. What's important here is the international was 0.02 a few years ago, and then 0.05, and they changed it to 0.02. These folks change their numbers every 5 to 10 years, whether they need to or not. They study this stuff forever. They take forever to make it. I've met a number of physicists along the way. It's an interesting crowd. But that number is going to drop for the national, and eye sensitivity is being appreciated. So get lead glasses. They're online. They're not expensive. You can fulfill what Dr. Zero was talking about as far as wraparound. You can get the eye protection. You can get your prescription, and you can get lead line, and they're a lot lighter than they used to be, and you're working against the cataract. So there's three types of cataract. There is the senile nuclear cataract, the one that takes years and years and years and years to develop. There's a cortical, and then there's a posterior subcapsular. 10% of posterior subcapsulars, or 10% of cataracts are posterior subcapsular, associated with diabetes, corticosteroids, trauma, and UV radiation. I have none of those associations. I have 40 years of ionizing radiation in the operator. So I did find 2.5 years ago, I had normal vision in my right eye. Within 6 months, I did not have normal vision. Posterior capsular cataracts progress within months, not years. So I had my right cataract done. And I went back to having 20/20 vision. 2.5 years later, within 6 months, the left eye, posterior capsular cataract, had the operation. I now have 20-year-old 20/20 vision. It's great, but I have floaters. The implant lens is thinner than the actual lens and subjects you to aqueous detachments, floaters, and then the back wall of the lens can't be completely removed. You're at risk for epithelialization behind the lens, recurrent cataract, They can zap that with a laser, but then that has the risk of more floaters and halos at night gravity. So don't do as I did, do as I say, stay away from the cataracts. So cancer risk, here's cancer risk and against dose. If you get 4 sieverts of radiation, you're probably going to die. Way here on the other side is 50 millisieverts. That's the annual NCRP dose I told you. 100 millisieverts is the statistically associated risk of a cancer. If you have a total cumulative dose of 1 sievert, by the NCRP, you have a 5% increased chance of death from cancer, and by the longitudinal study, a 1.6 risk of cancer at any age. So the protocol was in the research lab with a cadaver. We positioned mannequins around an operating room table. Each mannequin had a real-time Bluetooth dosimeter. Remember that the emitter is on the small side. I use the baseball analogy, and the bigger side catches it. So you want to be away from the emitter. You want to be away from that source. When it's flipped around, the emitter is bouncing off the table underneath. And by no means flip it around and put the emitter on the top. It's smaller, it's easier to work around, but that deserves a Darwin Award. It just has a tremendous amount of radiation. You're bouncing off the patient and scatter radiation, you just shouldn't do it. So we did 320 images. We took 2,240 dosimeter readings. We went through a number of permutations, and we came up with this. The biggest radiation exposure is standing next to the emitter. Across the table, there's a 6.5-fold decrease. Standing on the other side of the surgeon, or whoever's standing next to the emitter, there's a 7-fold decrease. Anesthesia, 10.9 less. And better hot than not, 70-fold decrease. They know that they're not at risk back there. And if you want to turn up the juice to get a better picture, they're not in a position to say much about it. And then at 6 feet and 10 feet, there's just not much radiation. Worst case scenario, lateral lumbar spine, the yellow button's on, highest exposure. You take 200 images, you could hit 0.05 in 34 cases, and you could hit 0.02 in 14 cases. You gotta be aggressive to get there, but it's possible. It's not like this is all make-believe. So what can you do next time in the operating room to reduce radiation exposure? Is the auto button still on? Shut it off after the first image. Who's next to the emitter? Step back if you need to. How many images have I taken? Do I need this image? Count. What is the CAK? I included this in my timeout. I looked around the room. Anybody who had a neck warmer on, I made them wrap it around their throat so that they were protecting their thyroid. People don't put them on, or they don't put them on tight. If you don't put it on tight, it's not doing you any good. I see people with the thyroid shield on and the waist on and nothing on their chest. This gets a Darwin Award. Absolutely. These people deserve to be publicly humiliated anytime you see it. Don't do it. So remember, just like the arrow inside the FedEx, when you walk in the operating room, look for the yellow button. Take your first picture, shut it off. If you do nothing else, that will significantly reduce your radiation. The other thing is the low dose button is really not much. I can give you details if you want to know, but just don't use the low dose button. There's a number of technicalities to it that really make it not very helpful. So in the operating room, the surgeon has a degree of resilience. You've been through a residency, you're tough, you've taken some hits. And the surgeon's smart. I mean, you passed your boards, you got a lot of things that you know. But then there's some differences. There's surgeons who really are immune to anybody else's opinion of what they think. There's those who are very sensitive to other opinions, and then those who just kind of go with the flow. But in orthopedics, probably not too many that just go with the flow. Whether you want it or not, you have a frame of authority. You just get it by standing there. And if you ever question that, ask your local defense malpractice attorney. He'll tell you what kind of authority and responsibility you have in the room. So make use of that authority. You're the big dog. I mean, you get to bark, you get to control the room. Now, there's different shapes to big dogs in the room, for sure. But what you're up against is what this person's thinking. He's thinking better hot than not. He's lighting the fire underneath. that, and unless you participate and unless you engage, it'll continue to happen. So when you are looking at your common unity proximal femur fracture that's short and embarrassed, you're not thinking about what button to hit. You're not thinking about your radiation exposure, and he didn't want to get yelled at. So I think the way out of this is to give him some authority. Learn their name, give them some respect, and give them a copy of my article. And educate them. Give them an idea of the button pushing and what they can do so that your PA or your assistant and the X-ray tech, while you're thinking about how to deal with the femur, they're playing with the numbers and they're reducing the radiation to the point that you have an adequate image, but you're not getting the same exposure. So you got to count. You're probably going to take more than 5 or 6 rounds, but you can't do the Jolly Green Giant belt-fed Gatling gun. There are people who just go nuts with the number of images. They put their foot on the pedal and they run, and it's just simply king. So there's a lot of different settings on the machine that are in the paper that I haven't talked about that the X-ray tech can use to decrease it, but it's all about BMI. The bigger the patient, the more radiation, the worse your image, and the idea is you can really tone down radiation a lot in a smaller BMI patient. So when you're thinking about how to do the fracture, you give up authority to PA and to the X-ray tech to be running the machine for you and get your radiation reduced. There's too much going on, I think, to handle. So stay safe, count your images, look at the CAK. And if you want a copy of the paper to give to your PA, to give to your X-ray tech, I'd be happy to give it to you. Send me an email and I'll send it to you. Read the discussion, forget about the materials, methods, and all that other kind of stuff. It's got a bunch of things you don't really need. Look at the pictures. And I made this discussion specifically as a paint-by-numbers orthopedic description so that we could all grasp it, learn it, and take it home and make use of it. So that's all I've got, and I will stop that.